I'm here with Pedram Hamrah. Pedram, you're doing really, really interesting work with confocal and the cornea and dry eye. Let me set this up.
Right.
So I see a lot of patients with dry eye. I guess we all see a lot of patients with dry eye. And to some extent, dry eye is kind of a final common pathway for a lot of different pathologies. You can observe whether there is an inflammatory aspect, whether there is an inflammatory keratitis that's associated with the dry eye. Can I get you to tell me about this a little bit?
So it started with me being frustrated about treating dry patients, because when I started my practice over 5 years ago, you did the regular routine things, and many times the patients didn't respond, were frustrated. So I became interested in actually doing live imaging of these patients, and with the confocal, you can get 800 times magnification, getting basically the cellular aspects of the cornea. Now, as people know, inflammation is a part of the pathophysiology of dry eye. And since dry eye is a continuum, we don't really know at the time you see the patient, does the patient have inflammation at the time, or did they pass an episode of inflammation? Are you dealing with the consequences of the damage caused by the inflammation? And as we know, when you put patients on steroid, for example, some respond, some don't respond. So with the confocal microscopy, since you can see the cellular changes, you can actually see the inflammatory or immune changes in the cornea live in these patients. And based on that, you can tailor your therapeutic drugs that you tailor to them, whether you should use anti-inflammatories, with how much you should use, use a lot or less. In addition, you can see the nerves, where you can see the neurotrophic component, and in some patients there's complete nerve loss or near complete nerve loss, and then neurotrophic, not to the level of like in severe herpetic infections, but pretty severe. And the final thing you can see is the epithelial changes, which you can see more objectively than on corneal staining. And based on this, we can kind of tailor the approach of, should we put the patient anti-inflammatory, do they need more lubrication, may they be a candidate of autologous serum tears to regenerate the nerves, and that's how we basically tailor it in my practice.
So an inflammatory finding can be, you know, it can be part of the disease process. It can also be a response to dry eye from a non-inflammatory etiology. Can you tell when you see inflammation in the cornea whether in a sense the dry eye is secondary to the inflammation, or whether the inflammation is secondary to the dry eye?
I don't think you can tell that, because dry eye is a continuum, and you have these inflammatory episodes coming in waves, like in rheumatoid arthritis. And whether the inflammation that you see at the time is a cause or a consequence, I don't think that really matters. The point is that you have to treat it.
Now, when you say that you can tailor therapy, is it simply that you look at the inflammatory status of the cornea and you say, therefore, I'm going to choose this therapy? Or can you actually get a baseline, institute therapy, and see whether the patient changes from baseline?
So I use it several things. For me, it's a routine test now, but it took a lot of effort to get there, having a whole team to kind of help with it being routine.
So you're using this clinically?
I use it clinically in every single dry patient, at least at baseline, and depending on how they do on follow-ups, on some follow-ups, at least every 3 months.
Yeah, can you use your findings, number one, is it simply that you use your findings to tailor therapy, or can you see changes from baseline once you've instituted
three
therapy?
things. One, the patient sees what happens in the cornea, so they have a feedback mechanism. Because if they're improving and they don't feel it yet, you kind of help them to go through the phase until they get better.
From an education standpoint.
They don't give up. Second, you kind of can decide if there's absolutely no inflammation, there's little lower for steroids, you maybe use it very infrequently to prevent it as a prophylaxis, or you can put them on cyclosporin or other drugs. If you see significant inflammation, I put them on a taper, but as you just said, you don't really know in dry patients when to stop the anti-inflammatories. And when you scan them and you see the inflammatory response changing or diminishing, that gives you a hint of when to decrease or when to stop the therapy.
Now, the thing that I like to do least is to ask people to generalize. Have you been surprised that certain therapies with certain phenotypic presentations work better or work worse than you otherwise would have thought?
Dry is multifactorial, so you don't have a single component to it. So A lot of times it's very complicated. You address one component, the patient gets some better, but they still have complaints because other aspects are not addressed. For example, you have a patient who may be improving the tear breakup time by treating the meibomian gland dysfunction, but they still have significant conjunctival chalasis, which won't not go away with that. And so the discomfort of that will reside versus the evaporative component, etc. So you have a culmination of different components of dry leading to the patient's symptoms. And once you address each of them independently, that usually helps to the patients get resolved symptoms.
Yeah, really, really great stuff. You know, I what can I tell you? I wish I had one in my office too. Pedram, thank you very much for spending time with us today.
Thank you, Josh.